All right, let's jump right into this rapid-fire explainer. Today, we are playing the role of diagnostic detectives. We're going to tackle the absolute high-yield differences between cytomegalovirus and the human herpesvirus strains 6, 7, and 8. So whether you're right in the middle of prepping for your medical board exams or you just really want to lock down those tricky virology differentials once and for all, you are in exactly the right place. Let's get started.
Here is the syllabus for our board prep sprint today. We'll quickly introduce the beta herpes viruses, dive into CMV across congenital, adult, and immunocompromised patients, break down the pediatric exanthems of HHV6 and 7, look at the HHV8 triad, and wrap it all up with those all-important high-yield differentials.
Section 1. Let's meet the beta herpes viruses, starting with our heavy hitter, CMV.
Section 2. We'll look at how CMV presents clinically in both congenital and adult cases.
Okay, so if you are reading a biopsy question and it describes an 8 to 10 micrometer intranuclear inclusion that is surrounded by a clear halo, lock in CMV immediately. Seriously, don't even second guess it. That is the classic owl's eye appearance, and it is the absolute gold standard pathological fingerprint for this virus.
Now let's talk congenital CMV, which, by the way, happens to be the most common congenital viral infection out there. When you get a newborn clinical vignette, you have to be on high alert for the blueberry muffin rash. This is actually caused by dermal erythropoiesis, and you'll typically see it show up alongside a whole cluster of symptoms like petechia, jaundice, hepatosplenomegaly, microcephaly, and periventricular calcifications.
But here's the massive, absolute must-know detail about long-term sequelae. It is a highly tested exam fact that 7 to 11% of infants who are completely asymptomatic at birth will still go on to develop sensory neural hearing loss later in life. Basically, congenital CMV is the single most common cause of non-hereditary sensory neural deafness in kids. You just cannot afford to miss that fact.
Moving to adults, watch out for this classic board trap. CMV is actually the most common cause of heterophile negative mononucleosis. And here's the clincher. Pharyngitis and cervical lymphadenopathy are incredibly rare with CMV. This perfectly separates it from Epstein-Barr virus, or EBV, which is heterophile positive and heavily features that severe sore throat and those swollen lymph nodes.
Section 3. Let's look at how CMV behaves in the immunocompromised, specifically transplant and HIV patients.
In solid organ and stem cell transplant recipients, you absolutely have to know the highest risk profile for a primary infection. It's a mismatch. It happens when you have a CMV seropositive donor giving an organ to a CMV seronegative recipient. That dangerous primary infection usually strikes within a very tight, highly tested window, right around 1 to 4 months post-transplant.
Now for AIDS patients, a CD4 count of 50 cells per microliter is your magic threshold. The second a patient's CD4 count drops below 50, you have to actively suspect, screen for, and be ready to treat CMV retinitis.
So what exactly does that retinitis look like? You're looking for visual symptoms caused by granular white areas of necrosis. They spread centrifugally across the retina, and they're often accompanied by vessel sheathing and hemorrhages. Make no mistake, this is a sight-threatening emergency that requires immediate antiviral therapy.
Speaking of therapy, let's build out our pharmacology differentials. Keep these caveats totally straight in your head. First line is ganciclovir, but if the question mentions a UL97 gene mutation, you're going to switch to foscarnet. What about highly resistant strains? Marivavir is the newly preferred agent there. And memorize this one. Letermovir is strictly used for prophylaxis in stem cell transplants. You never ever use it for active treatment because the virus will develop rapid resistance to it.
Section 4. Let's pivot to HHV6 and 7, known for their classic pediatric exanthems. For roseola infantum, caused by HHV6, the clinical timeline literally gives you the entire diagnosis. The kid will have a spiking high fever for 3 to 5 days. Then, there's an abrupt drop in temperature, defervescence, and only after the fever fully breaks does the maculopapular rash finally show up. High fever first, then rash. It's the exact opposite of measles, so keep that straight.
But HHV6 has a much darker side when we're dealing with immunocompromised patients, specifically stem cell transplant recipients. In these folks, it doesn't just cause a little rash, it causes full-blown limbic encephalitis.
Look for vignettes mentioning sudden memory loss, confusion, hyponatremia, and very distinct signal changes in the temporal lobe on an MRI. Oh, and a quick side note for pediatrics, HHV6 is actually responsible for 10 to 20% of all infantile febrile seizures.
Moving right along to HHV7. This one is heavily associated with the dermatological condition called pityriasis rosa. When you hear HHV7, your brain should immediately scan for the phrase Herald patch. That's a primary solitary plaque on the skin that eventually erupts and evolves into a wider rash following a superclassic Christmas tree distribution, usually right on the patient's back.
Section 5. HHV8, the KSHV triad, that is highly endemic to sub-Saharan Africa.
You've got to firmly lock this HHV8 disease triad into your memory. Number 1, Kaposi sarcoma. This shows up as violaceous patches, plaques, or nodules on the skin and mucous membranes, incredibly common in HIV/AIDS patients. Number 2, primary effusion lymphoma, which is a rare body cavity-based B-cell lymphoma. And number 3, multicentric Castleman's disease, a lymphoproliferative disorder that relies heavily on rituximab for its management. Get those 3 down cold.
Finally, Section 6, High-Yield Differentials. This is where we put it all together.
If a test question features a newborn with that blueberry muffin rash we talked about, immediately pull up your mental torch differential table. CMV is the most common cause, sure, but congenital rubella and toxoplasmosis can also cause that exact same rash. So how do you tell them apart? Look at the eyes and the ears. Rubella brings cataracts and congenital heart defects. CMV brings hearing loss and periventricular calcifications. And toxoplasmosis, that brings diffuse, totally unorganized calcifications in the brain. And let's cleanly contrast the classic presentations of our HHV strains one last time. If that high fever completely breaks right before the rash appears, you're looking at HHV6 roseola. If the patient has a Herald patch that turns into a Christmas tree, it's HHV7. And if you've got an immunocompromised patient with violaceous vascular nodules, lock in HHV8 Kaposi sarcoma. Organizing these distinct buckets is literally your cheat code for flying through the virology block.
By now, the answers to these core questions should instantly leap to your mind. You've got the exact tools you need to separate CMV from the other HHV strains. But remember, these viruses are absolute masters of disguise. They hide in plain sight with overlapping fevers, rashes, and vague symptoms. So the real question is, next time a confusing clinical vignette crosses your desk on exam day, are you going to be able to spot the imposter? Keep crushing those differentials. Thanks for joining me on this explainer, and happy studying.